Hey everybody, it's Dr. Eric Balkavage, and I'm joined by my co-host, Dr. Erica Riggleman. How are you today?
I'm doing great. How are you?
I'm doing fantastic. We're back for another edition of Thyroid Answers podcast, and today we're going to do another listener questions, and then hopefully we can give them some answers. So I got a list of maybe 10 or 12 questions that maybe we can get through in the next hour. So I'd say we hit the ground running. Did you have any major things that you think questions that we need to talk about before we get into the listener questions?
No, I think that's the best thing is to get into the questions that people submitted and want to hear. I mean, that's why we do this podcast, is to give people answers about questions that they have about their thyroid. So if these are real questions from people that are posting on Instagram or Facebook, then I say we just jump right in and start answering their questions.
Yeah, so I agree. So here's the first one. When does hypothyroidism start?
Yeah, I think that's a tricky question, because it's not like there's like a line in the sand where it's like, this is exactly when it starts. I think that we've alluded to on this podcast many of times is that there are things that start to happen at the cellular level that kind of build up, and then the body does its best to compensate. And I think then over time, things, as the body tries to stay in homeostasis and really trying to work to stay in that kind of normal value, that things start to kind of compromise. And I think hypothyroidism is just a compromise of a system because other things are going on. So I don't think that there's a true line in the sand. I think that there's many years of things building up that you may not even have realized or even had symptoms of, that have led to you having hypothyroidism. And then all of a sudden it's like the straw that breaks the camel's back. All of a sudden you now have labs that show that you're hypothyroidism.
Yeah, so I think kind of build on that when we talk about when does it start, right? Because it all really depends on the set of lenses you're looking at it through, right? So if you're a medical physician, hypothyroidism starts what they call primary hypothyroidism, which is a treatable thyroid condition. Technically starts when your TSH rises above lab range and your T4 drops below lab range. And that's when hypothyroidism becomes primary and it becomes a treatable condition. So I think from an allopathic perspective or a medical perspective, they would say that hypothyroidism becomes a treatable condition when those things happen, okay? But before that, could you have hypothyroidism? Absolutely. We've talked about this on the podcast, that really the symptoms of hypothyroidism start when there's insufficient levels or limited amounts of T3 reaching the receptors inside the cells, and that can cause hypothyroid signs and symptoms. You can have those for weeks, months, years before TSH ever goes out of range or T4 goes out of range. So I guess it really depends on the lens. And as you were saying, we would look at hypothyroidism as a cellular issue many times, because when we define what causes hypothyroid symptoms, it's the lack of T3 at the receptors. So that's what drives the signs and symptoms. So somebody could have a tissue or cellular hypothyroidism going on as soon as they have reduced T3 hitting the receptors, right? Mm-hmm. That can trigger signs and symptoms. That can be a tissue hypothyroid state. That doesn't necessarily mean, however, that it's a treatable condition at that point in time, especially with thyroid hormone replacement therapy, because many times, as medical guidelines kind of state, that you can, if you provide thyroid hormone for somebody who doesn't need it, you can actually create some adverse signs and symptoms. A lot of times you see these people get hyperthyroid signs and symptoms when they're treated inappropriately. So I think for the listener who asked this question, they didn't give a lot of detail. It was a weird question, and one I'll probably touch on an Instagram post, but it really is based on the perspective. So a medical profession, they're going to say it starts when there's something that matches the diagnosis that I can treat. From a functional medicine perspective, at least from mine and yours, maybe the hypothyroid state starts when there's excessive cell stress and the body's sensing danger, and the deactivation of thyroid hormone is part of that danger response, that cell danger response. And so a hypothyroid condition starts then. That doesn't necessarily mean it, though it's treatable or needs to be treated with medication. You need to get to the root issue, find out why your body's trying to adapt physiology. So
yeah, and I even think that the listener who probably wrote that is looking at this like, just tell me when it starts so that I can either prevent it or I can fix that one thing that may have started it. And we often try to look at health conditions and make it too simple and say that it's really black and white, that this is the one true cause. This is when it started. Oh, it was when you had your pregnancy, or when you had this, or they're looking for that one thing. And I think that unfortunately it's many things, and it's not that simple, and it's not something that comes on overnight. It's not like you wake up one day with hypothyroidism. It's a gradual, it's a process. I mean, that's with most things in health. It's a process that happens over time. And then finally you reach the criteria to have hypothyroidism and get diagnosed. But I think where it really starts is way, way, way before that.
Yeah. And we've talked about this, 90% of the thyroid gland is damaged or has lost, you've lost 90% of the output of the thyroid gland by the time we actually diagnose it as primary hypothyroidism. So that's really not the beginning of it. You've lost 90% of the function of the gland. So there's actually been damage to the gland many times long before the gland becomes exhausted. So some other mechanisms going on. We've talked about it, that hypothyroidism is more of an adaptive mechanism to cell stress. So for us, I think, and for the patient, and maybe I think you're right when she's saying, so when do I think maybe from this perspective, this is how I looked at it, like, so when does it start? When I start having signs and symptoms because my doctor says I don't have it, right? Mm-hmm. Or does it start, or are those signs and symptoms I have not hypothyroid symptoms because my TSH is still normal? Like, at what point do the symptoms I have that I'm experiencing become caused by hypothyroidism? Because my doctor's saying they're not, even though they seem like hypothyroid symptoms, they're not because my TSH and T4 are normal, but they seem like hypothyroid symptoms based on everything else. So when does it actually start?
Yep.
And I think that just kind of reinforces what we just said is, if you have signs and symptoms, you have reduced amounts of T3 hitting the receptors in the cells. You have a tissue hypothyroid state. It's not treatable at that point with thyroid replacement hormone therapy. It doesn't fit your doctor's criteria that an organ has become diseased and now can't work anymore. But you probably start to have a level of hypothyroidism in the tissues, either as soon as you notice signs and symptoms or your doctor is starting to notice the signs and symptoms.
Yeah, absolutely.
All right, ready? Question 2?
Yep.
And you kind of led into this, was a good segue. And the next question was, what causes hypothyroidism? So, and I'll give you a little lead into this one. So this was somebody who was trying to find the thing, like, is it gluten? Is it Epstein-Barr? Is it, she wants to know what the thing is. So how would you answer that question? What's the thing? And you already kind of started on this, so I'll let you jump in.
It is not one thing. I think that it is a combination of, we don't live in a bubble. It's not like you can have one control. I mean, I don't even think they could even do a study to try to even prove that it was one thing. Because, even when we look at all these things, we're talking about the cause, but there's so many different things that contribute to it. And so, yeah, there isn't one thing. Unfortunately, it's not one thing. It's a combination of things. I often call it the perfect storm, whether that's, and, we talk about this before, it comes down to the stressors, whether that's, physical stress, chemical stress, emotional stress, pathogen stress. It's a combination of all those things working in an environment that then leads to the cell environment not doing what it needs to do and not reacting the way that it should. And then eventually we start to produce symptoms and then we get diagnosed. So I think that it's that accumulation of stressors on our body that accommodate, and over time we start to develop it.
Yeah, and so I agree with that. There's not typically one thing. Sometimes there's the one thing that pushes us over the edge, but it's the load over time. And we're all adaptable to a certain amount of stress. And if we have that stress and we allow that stress to calm a little bit, then we actually get a little bit stronger. We can manage more stress.
Mm-hmm.
And if we let that stress kind of, let our body recover from that stress, we keep kind of adapting and get more resilient. The problem is that our stress levels don't seem to really go away, right? They can become cumulative and cumulative and cumulative. And instead of making us stronger, that just breaks us down. I tell patients all the time, when I'm trying to explain, that stress is not necessarily a bad thing. And then they argue or they're like, well, you said stress has created my issue. Right, it did. And we're not going to get rid of it all. Well, then how am I fixing myself? It becomes this kind of loop that's hard to understand. But if we were going to take somebody who never ran before and I said to them, hey, we're going to run a marathon right now. I mean, and we went, they would probably die, right? Isn't that what happened to the first guy who ran the marathon? Was he died because they weren't conditioned, right? Mm-hmm. But if you take somebody who's conditioned, they can run a marathon and they feel fantastic when they're done, right? Especially somebody who does like ultra marathons. They may think like an individual marathon is like a piece of cake. So it's not that stress is really terrible for us, but there's that sweet spot. There's a hormetic effect, they say, where too little is not good because now you don't have enough things to challenge you, to help you become more resilient. But if the stress is excessive and persistent, then you never get a chance to recover. The same thing with that training for that marathon. If I train somebody like over 12 weeks, build them up, let them recover, build them up, let them recover, they'll be able to do that marathon in 12 weeks. But if I do it to them in one day with no training and just keep pushing them, it's too much, right? So the same stressful event, a 26-mile race, prepared for appropriately, can be exhilarating. And for somebody else who prepared inappropriately, it could be a disaster, right? And so the same thing when it comes to when we talk about what causes hypothyroidism, it's the load for most people. And I know it makes people a little sometimes unhappy when I do posts. I'm sure if you talk about it too, you're talking about life stress and sleep and people
you get eye rolls.
Yeah, everybody wants you get the thing, and unfortunately there isn't a thing. Could it be like, hey, it was after my pregnancy? Absolutely, but why were you more susceptible after your second pregnancy? I don't know. Well, maybe because you never fully recovered from the first one. Maybe your blood sugar regulation. Maybe you weren't sleeping. There's so many factors that play into it. So I think for the listener and the person who asked me that question, it could be multiple things, and we have to be careful. Just because your friend had Epstein-Barr virus and their Epstein-Barr virus is addressed and they did better, that doesn't mean that's your cause. And I think that happens sometimes is whatever the new sexy, shiny trigger is, everybody jumps on it. They go to a seminar and everybody's got, Epstein-Barr is the cause, or mold's the cause, or gluten is the cause. And they totally ignore what all the other potential causes might be.
Yeah, and I think that the take-home message is that, yes, there are many, many causes and contributing factors, but if you work on just a few of the big ones, you may be able to recover. You get that resilience back, and you may be able to handle those other stressors without even working on them. And then also focusing on the ones that you have the ability to work on. There are some stressors that you're never going to be able to work on. And sometimes you just have to learn to live with those and work on the ones that you do have control on, and understand that you don't have to work on uncover every single stressor to get better. If we start to chip away at some of these things, you do start to get that resilience back and start to regain your health.
Yeah. I mean, it's because it's the load versus everything else. You reduce the stress to a point that the tissue can start to recover. So it doesn't matter which one it was. Like if you put a bunch of weights on a piece of wood and it sagged, which one was the piece of wood which weight was the one that caused it to sag? Doesn't matter, right? You just need to take enough weight off to take the sag away. So is it the blue weight, the red weight? I don't know. Just take one of them off. Oh, it proved it a little bit. Good. Take another one off. Huh. Okay.
Yeah, I'll get patients who come to me who say, well, what about this? What about this? What about Epstein-Barr? What about that? And I say, yeah, that we can certainly attempt to see if that's what your trigger is, or we can work on some of these things. And each person's thing, gluten may be a bigger stressor, it may be a bigger weight on that wood in, terms for a person than somebody else. And so taking away gluten for one person may do nothing. Taking away gluten for another person may dramatically change how they feel. So I think that these stressors are all individual and they all have different weights depending on the person.
Absolutely. That was good. That was good. All right. You ready?
Yep.
And we've talked about this. We've had podcasts on it, but this person's question was, is fasting bad for hypothyroidism? I say no, because I use time restricted eating all the time as a tool for my patients. I was asked, other people talk about, and you see this sometimes on different blogs and posts, that people who have hypothyroidism should not fast. They should not do time restricted eating. They should eat every 2 to 3 hours to manage their blood sugar. I don't believe in that at all. Matter of fact, I think that's the fastest way to continue to make yourself more insulin resistant. One of the reasons you have insulin resistance is because you have a tissue hypothyroidism going on. What's the difference then when we're talking about whether fasting is healthy or it's not healthy versus I think people get confused with calorie restricted diets, right? And I think it all comes down to satiety. When you do time restricted eating, you're having 1 meal a day, 2 meals a day, and you're eating enough that you're actually getting signals of satiety to the brain. It's not a danger signal, as long as every 24, somewhere in that 24-hour cycle, your brain is getting signals like, hey, there's food coming in. I think what gets people in more trouble is when they eat 2 to 3 or 3 to 5 small meals per day. It's like 200-300 calories. They're nibbling each all day, but never really getting satiety signals. So they're constantly hungry. That creates a danger signal. So I think the difference to me is not that time restricted eating or fasting is dangerous or concerning for somebody with hypothyroidism. They may need to do it, kind of get there slowly, right? If they're used to eating all day and having little tidbits all day, or eating 3 to 5 meals per day, they may need some time to transition to time restricted eating. But I've been doing, time restricted eating with my patients for decades, and the vast majority of those people do really, really well. And the primary difference I would say is because when you time restrict eat or do intermittent fasting appropriately, you do not create danger signals because you're creating signals of satiety.
Yeah, I think the main take home with that one would be start slow. If you're not used to doing, intermittent fasting, start with 8 hours, 10 hours, 12 hours, and work your way up to an 18 or even more hours of a fast per day that you're looking for. The other thing is you still need to be eating enough calories. That I think that when people are trying to do intermittent fasting, they'll end up only eating like 500 calories in a day, and that's not enough to sustain, and your body may go into, more of a starvation type of mode and think that, a famine's coming and that's going to raise stress hormones and that's going to add to that stress of the body. But I think that, our bodies are meant to have periods of time without food. It's a great way to kind of cleanse and purge and get the system nice and clean. The digestive tract does a great wonder when there's nothing in it. It's like a cleaning process. If there's constantly food in there, you never really get that cleaning process. And then also one little tidbit is how you break your fast. I think that's really important too. Obviously, if you're doing intermittent fasting, you don't want to be breaking your fast with, a cookie or a cupcake or, something that's full of sugar. And you really want to be trying to eat, if you're restricting your calories, you still want to be able to get those nutrients in. So it should be very nutrient dense food.
Yeah. I think at the end of the day, and we talk about individuality, if you're going to do time restricted eating, can you do it with somebody who, if you have hypothyroidism, can you do it? Absolutely, you can do it. You probably want to do it with some guidance if you're having some struggles. But I am definitely not in the camp of those who say, hey, everybody who's hypothyroid needs to eat 3 to 5 small meals per day. I just don't think that's a great strategy. I just don't see those people doing well and really burning a lot of calories. One of those things you have to consider if you're a person who's saying, hey, I'm trying to do this to help burn fat, your body's not going to dip into your fat stores unless there's a reason for it. So if every 2 hours you're bringing food into the system, why would it dip into the fat stores to begin with, right? There's constant low levels of food always coming in. And if the body does get danger signals like, hey, I'm never getting satisfied, then your body's going to go into, hey, I got to store calories because I don't know that I'm going to get enough in the day. So I think it's key for most people. If you feel fantastic and 3 to 5 meals per day and your blood sugar is normal and you don't have weight issues and you feel great, you're sleeping great, and your energy is fantastic, maybe it's good for you. But if you're struggling with weight issues and you're hypothyroid and you've been eating 3 to 5 meals per day and still can't lose weight, then maybe that's not the right strategy for you. It's time to make a switch. All right, ready? Another one?
Yep.
Ties right into that one. My weight is not budging on keto and levothyroxine. Can you tell me why? What's your thoughts?
Keto may not be right for that person. I think that we had kind of alluded to that diets are very individualized and that you've got to try different things. I would reevaluate what your strategy is for doing keto. A lot of people do keto wrong. If you're eating mostly, I mean, you may have dairy issues, and if you're eating mostly dairy, that can contribute and create, inflammation and can make you hold on to the weight. So I think that that's a component of it. Some people just don't do well with keto. You may want to try, you don't have to be keto, but you maybe want to do intermittent fasting, or maybe we try carnivore for a little while. I think that there's nothing wrong with trying to switch it up and try other diets. If keto's not working, then it may not be the right diet for you. So let's switch it up.
Yeah, I would say if somebody's ketogenic, right, and they need to be able to, let's do it this way. They're hypothyroid, right? And probably if they're hypothyroid, that's why they're on levothyroxine. They're probably still not losing weight, so which is why they probably went keto, right? And so if they're hypothyroid, then we would typically say there's some type of, we don't know the mechanism that triggered it. Maybe it's iodine deficiency. Maybe it was medically induced. Maybe it's just Hashimoto's, right? So if it's Hashimoto's, then we'd say maybe there's an underlying danger mechanism going on. And just because you started taking levothyroxine, if your normal physiology didn't go back to normal, you still have a danger response. So your body's not burning energy efficiently. Your mitochondria, you have fewer mitochondria. They're not as efficient as they were. Your body's not in growth and build mode. It's actually in cell defense mode. So that would be step one. The cell danger response is still there. The second piece of that is, hey, I'm doing keto and my weight's not budging. Well, how many calories are you consuming? A, right? B, are you actually absorbing all the fat, right, that's coming in from your diet? Or do you have a gut issue, which is one of the reasons why you have a thyroid issue?
Had their gallbladder removed.
Right, or had your gallbladder removed, right? So maybe that's part of the issue. The third issue is if you still have that tissue hypothyroid state on and you're doing keto because you're trying to drive kind of a fat-driven metabolism, but you don't have very good thyroid physiology in your cells and tissues, you're not going to drive that aerobic fat-driven metabolism to be very efficient. So you're probably still not going to lose the weight. So my easy answer for that person is there's still some underlying level of cell danger going on, cell stress response going on. Even though your TSH is probably normalized with your levothyroxine, you don't have good tissue thyroid physiology, or otherwise you'd probably already start to be seeing the change. If your ketogenic diet is one that you're not consuming massive amounts of junky ketogenic type stuff like
keto cookies.
Like Erica got into, and you're doing all the other things appropriately, I would say the underlying mechanism is you still have a cell tissue or cell danger response and cellular hypothyroidism going on, even despite those two things. So I would take a step back and say, all right, let me have somebody help evaluate me for what's creating that excessive cell stress, driving the hypothyroid state, and preventing me from burning fats efficiently. Next one was, why do I initially feel improvement when I start thyroid hormone therapy, but then it tapers off? So I'll start with that one. Usually somebody gets diagnosed hypothyroid, they get put on thyroid medication. We hear this quite a bit. They have what they call the honeymoon phase, where their body think about it. So when you get diagnosed with primary hypothyroidism, you've lost 90% of the function of the thyroid gland. So there's not much thyroid hormone in the bloodstream to support the tissues. Now, we talked about tissue hypothyroidism many times is the beginning of it. That triggers autoimmunity or sets the stage for autoimmunity. The autoimmunity then destroys the thyroid gland. Then you get diagnosed with primary hypothyroidism. If you have no thyroid hormone or limited thyroid hormone being produced by the gland, there are some cells and tissues that really are struggling. And so if you put any thyroid hormone into the system, those tissues are going to start to get a base level of thyroid hormone to kind of deal with basic primary functions, and you're probably going to feel better. The problem is that if you still have that cell danger response going on, once you get those kind of really foundational things addressed or those base levels of thyroid hormone needs met, then the body's going to go back to the same thing it was doing before. Some of those tissues are going to start deactivating that thyroid hormone, and you're going to start to see, oh yeah, we got to downregulate this thyroid metabolism. So I think what happens for most people is they get a thyroid medication, they feel good, that's their, hey, we're getting some into the system, and then it's gone, right? Or then their body kind of goes back to their base. And so if they switch to a T4, T3, they feel their honeymoon phase again, and then it goes away again. I think I see that it doesn't really matter what the medication is. It's just the initial, they're so depleted, they get something, and something's better than nothing. But then their body still has the cell danger response. So there's still some deactivation in some of the tissues. So some of those signs and symptoms persist.
Yeah. And I could see how people get frustrated with that, because they get the illusion that, oh yes, I finally found the pill that's going to work for me. And then they think, oh, well, it stopped working, we just need to move on to the next one. And what they have to realize is that the pill's not fixing what got you there in the first place, that, it's artificially making you feel better. It's satisfying those bodily needs that your body needs for thyroid hormone. But at the end of the day, there's still something going on that caused it in the first place.
Right. All right. Ready?
Yep.
Why does it seem my insomnia is worse the stronger my thyroid medication dose? So I'll tell you I give you the background on this. This is a person who said their TSH was within, their doctor, the person was diagnosed with hypothyroidism. They were put on thyroid medication, brought it back into the reference range. Doctor was happy, but patient was still struggling with weight issues and other symptoms. So her doctor said, we're gonna try and drive your number lower. So he wanted to get the number under 1 and drive it lower. So she's like, the more he gives me, the lower my TSH goes, the happier he is. But the stronger that dose, the more insomnia, the more brain fog, the more irritable I am. Why is that occurring? And is it related? Her doctor didn't seem to think that her insomnia was related to the thyroid medication dose. Any thoughts?
Well, I think it's definitely related. I think that there's part of that deactivation, and clearly what caused her issues in the first place hadn't been addressed, and just throwing more medication at it isn't going to fix it. And the body's really trying to shut things down, especially at a brain level, to try to get satisfied thyroid hormone levels. But when you're throwing more, there's going to be deactivation of the normal mechanisms. That's going to cause to more anxiety, more depression. Obviously, if she's still struggling with all those symptoms, something's not being addressed at the cellular level to really fix it.
Yeah, I would say that, and we talked about this on the podcast previously, that when we talk about the brain and the body, right, the hypothalamus, which we'll say is the brain, is, at least 10 times, the receptors of the hypothalamus are at least 10 times more sensitive to thyroid hormone than the peripheral tissues. So it takes a small amount of thyroid hormone to kind of saturate the hypothalamic and the brain area. And as soon as those areas are saturated, then you are essentially revving up, kind of creating a hyperthyroid state in the brain. And so two things are going to occur. You're going to have this more you flood the brain with thyroid hormone. You're going to get this hyperthyroid state in the brain, which is going to make you more edgy, more anxious, right? So that's and it's also going to increase the activation of your sympathetic nervous system, which is that fight or flight system. So, if you're running from the proverbial tiger, you're probably not going to lay down and take a deep sleep because you're trying to stay alive. So when your doctor's providing you that thyroid hormone, he's trying to drive that lower, thinking that the lower they drive the number, the more thyroid hormone in the system, the more we'll get into the peripheral tissues. But not aware that, hey, if you put more thyroid hormone into the system, it actually can create a hyperthyroid state. And so I guess the next piece to that would be that somebody would say, well, I have insomnia, I have brain fog, I have anxiousness, I have irritability, but I can't lose weight. Why, if I'm hyperthyroid in my brain, why is my body not hyperthyroid as well, right? Why can't I lose the body fat? And part of the reason for that is as soon as the brain becomes saturated, sympathetic nervous system kicks up, but then there's signals sent to the tissues to deactivate the enzyme that converts T4 to T3. So in an effort to normalize or lower TSH below the lab reference range, doc's increasing your fight or flight system, ramping up that fight or flight. So that's going to disrupt sleep symptoms. And then your the body proper gets signals that, hey, brain's flooded, so we need to take this T4 that's being forced into the bloodstream, and we need to, we're not going to be converting that to T3. So the enzyme called deiodinase 2 gets what we call ubiquinated or deactivated, so you can't convert the T4 to T3. So there's plenty in the bloodstream. It may even be getting into the cells, but at the cells, there isn't deiodinase 2 to convert it. So what's left, it's going to get converted to reverse T3, or just get metabolized out of the body. And reverse T3 is the inactive, essentially, form of thyroid hormone.
Yeah.
Next question. If I've tried T4 medication, T4, T3 medications, and T3 only therapy, none of them have fixed my hypothyroid symptoms, what is left? So this is a frustrated person, right?
Yeah.
This is a person who's I did Synthroid, levothyroxine, I did tyrosine, I did Armour, I did NP thyroid, I did, now they're doing T3 therapy, right? I'm not sure from this if they're just doing T3 therapy or they're doing T4 and then a separate medication of T3. But I think they're at a point where they're like none of this is working. What's left? I mean, what are the other possibilities, right?
At this point, I think that's where you need to seek out somebody who does functional medicine, because you've got to take a different approach. It sounds like what this person has done thus far has been traditional medicine. You've gone to your endocrinologist or your traditional doctor. You've got the standard of care, which is thyroid medication. Now it's time to take a little bit deeper look and say, okay, maybe we need to look beyond the medication. Doesn't mean that they won't need medication to help them, but I think that there's deeper things that need to be evaluated to maybe get them across that finish line.
Yeah, I'd agree. This is a person who's probably did a conventional endocrinologist, right? Primary care or conventional. That was the T4 therapies. Then they went to an integrative practitioner who did a T4, T3. And then when that didn't work, they probably did somebody who's really on the edge as a medical provider, probably did just doing just T3 therapy. But I think you're right. At this point in time, it's time to look at a true like functional medicine approach, which isn't, hey, let's just put a different medication in. Let's figure out why the cells don't want to use the medication that we're providing. It doesn't matter which one. And I think that kind of goes to the analogy, if your car wasn't running well, you know, your medical doctor may say, just put gas in, right? The integrative physician may say, well, you got to put this new hybrid gas in, that'll make it run better, right? But it doesn't matter which gas you put in if the spark plugs are all bad, right? So what you need, if you've tried all the different types of medication, said, hey, we've tried to put as much all the different forms of medication in, and I still don't feel well, what's going on? The answer is your cells and tissues are taking that thyroid hormone and they're deactivating it. And so there's a cell stress response or cell danger response going on. Your thyroid physiology isn't broken. Your thyroid physiology is adapting to what's happening at the cells and tissues. So if you have excessive cell stress going on, then your tissues are going to start deactivating thyroid hormone. It doesn't matter if it's T4. It doesn't matter if it's T3. It doesn't matter if it's a combo T4, T3, or it doesn't matter if you take T4 in the morning and T3 pulse through the day. It doesn't matter. The cells and the tissues are trying to slow metabolism down. And I think that's one of the things that should become, you know, something that where you go, oh, okay, now I finally get it. It's not I just need more. Your body stopped allowing the thyroid gland to make it in the first place for a reason. And you just saying, well, forget the gland, we'll just put more in and not be aware that there's a problem at the cells and the tissues. That's why I think people get stuck in this condition.
Yeah. It's often just not as simple as take a pill. It's, I think with any sort of condition, there's deeper things, and you've got to want to evaluate deeper. If you're just looking for the next pill, you're probably always going to struggle with symptoms. So you're probably not going to find that magical pill. I haven't found that magical pill yet. I don't think you've found that magical pill yet for everybody. So, you know, you've got to find what got you there in the first place and address those things.
And I think it's tough for the person who's struggling, right? Because they are used to, we all grew up in the medical paradigm where tell me what your signs and symptoms are and I'll give you something for it, right? And we thought that was good healthcare. That was never really good healthcare. That was disease management, right? And crisis care and disease management have their place. But if you're looking for how do I actually fix my health, the only way to fix your health, especially from a long-term strategy, is to identify why your health is compromised to begin with. You can't ignore the fact that something in diet, lifestyle, environments, habits, behaviors is contributing to how you are where you are. It doesn't mean that it's your fault, like you need to be blamed for it, but there's something in your health, your lifestyle, your behaviors, your habits, your environment that's contributing to a reduced state of health. You can't band-aid that for an extended period of time and expect to be healthy. You can manage your signs and symptoms, but you can't be healthy unless you get to those root issues. And as Eric has said, I mean, it's work. And, you know, when we're frustrated and we don't feel well, I get it. We all want the quick, I just want something to make me feel better. That's the Band-Aid mode. And what happens to most people is they want that Band-Aid mode because it's easy. I would too. But then when that doesn't work, then you got to start digging in and saying, all right, I got to get to find the real issues here. And that's when the work begins. It's also when I think people can get really frustrated with their medical doctors because they start to look at functional medicine blogs and things and take those ideas and concepts back to their endocrinologist who has no idea what those things are about, doesn't know what to do with those things, and doesn't have any tools to help them with those things. and says, I don't know, that none of that matters. All you need to do is take your medication, and people get frustrated. Well, you can't ask your endocrinologist to do functional medicine. That's not what they do. They prescribe medications. That's their job. So they're doing the Band-Aid approach, but if you really want to get to root cause and you want to improve your health and address why you got sick, or maybe why you developed a hypothyroid or a blood sugar issue or hormone issues, you got to address the root cause issues. And I think the functional medicine practitioners are the people in the best position to address the root cause issues.
Yeah, absolutely.
All right. So next one, I think, did I ask this one? Is T4, T3 medications, are they better than T4 only medications? So I'll give you my opinion first.
Yeah, go ahead.
So if you asked me this about 5 years ago, I might have said T4, T3 medications. Now, for the vast majority of people, I would probably say I would lean towards T4. Here's why. Because as we've talked about on multiple podcasts and even in this one, most people who have hypothyroidism don't have it start at the gland first. It develops as a result of some type of cell stress response, cell danger response, and the hypothyroidism initially at the cell level is an adaptive protective mechanism. Potentially the hypothyroidism that starts with the immune infiltration of the gland, what we call Hashimoto's, is adaptive protective mechanism as well to slow down the metabolism. So in that situation, we want to put enough thyroid hormone into the system for the body to adapt, so we can support the basic needs while we try and fix things. But if your downstream thyroid physiology is working away from the gland, there's no cell danger response going on, right? Cells and the tissues are all healthy and fine. They just need thyroid hormone. Then it really doesn't matter if you give T4 or T3, because the vast majority of what's circulating in the bloodstream is T4. So the body should be able to take that T4, convert it to T3 efficiently if all the downstream mechanisms are important or are working appropriately. But the vast majority of people, they aren't working really well. So that's why they continue to have symptoms. My concern about T4 and T3 combos or just T3 therapy with these people is that the likelihood that they're going to increase their sympathetic nervous system, like we talked about before, that taking a T3 medication in these situations, T3 is going to be transported into cells at an easier rate. And so that we have the tendency to see more people have, in my opinion, more hyperthyroid type symptoms neurologically with T4, T3 combinations, whether it's like an Armour or a THRT or if they're taking T4 and T3 separately. So I just see the people who wind up switching to the combination meds, they feel a little bit better symptom, in their periphery, maybe some of the signs and symptoms are a little bit better, but I see the people that come to see me that have more insomnia, more brain fog, more neuropsychological stuff going on are on T3, some form of a T3 therapy, whether it's a T4, T3 combo or separate T3. So I've really leaned away from those combinations when somebody still has a chronic cell danger response going on. I would rather they do the smallest amount of T4. That way we're not getting too much T3 into the system. There's still some resistance to the T4 and we're not making those signs and symptoms worse. If the cell danger response goes away and they're take thyroid hormone, then maybe everything else works great. Maybe a T4, T3 combination works better, but technically they should be able to take that T4, convert it to T3 efficiently and feel well. I think the biggest reason we started seeing more people needing to switch to those things is not because T4 doesn't convert as well as we want. It's because the body's in a cell danger response, and the body's deactivating that just like it did their own endogenous hormone.
Yeah, no, I totally agree. And I think that T3 often is used as almost like a crutch so they don't have to work on some of those things. You know, if they don't have it, then, oh, I feel bad, but I also don't want to put in the work. So I think people use that as a little bit of a crutch. I think that if we can get all the foundational things and the pathways working, T4 is a great option if you even need it. Some people don't even, you know, at the end of the day may not even need it. And if we can get you on just a small dose, that's a great thing to keep everything in the system working the way that it should. You know, I just think sometimes T3 is a little bit of a crutch for people to not have to work on some of those other things.
Yeah, and I think sometimes what we see is that there's, you know, people probably more in the integrative space, some in the functional medicine space, that are saying, hey, that T4, that's, you know, that's the inactive form. We're going to be more progressive and give the T3 because that's the active form. But I just don't think that's the right strategy for the vast majority of people. There's a reason the body doesn't make, the thyroid gland doesn't make a lot of T3. Is because T4 that's circulating is the body's kind of backup in reserve. The thyroid gland has a bunch that's in backup in reserve, but your T4 value, when you look at your total T4 and free T4 values, I mean, that's your circulating reserve. There's always a ready amount of reserve. T3, the half-life of T3 is really, really short. And so that if you're only doing T3, you're going to have to take that with some frequency. It doesn't hang around very long. That's not how the body really set the system up. So I think we're probably better off with T4 now. Eric and I are both talking about this. Neither one of us is a medical doctor. We don't prescribe medication. When we have patients that come to see us and ask us what's the best thing, you know, we can have these types of discussions, but ultimately it's up to their primary care physician to make the decisions, but as to what's most appropriate. And I would say most classic endocrinologists are giving a T4 medication. It's usually the integrative physicians that have switched to T4, T3, or pulsing some T3 along with their T4 medication. But I would say you're right. You know, the vast majority of the time, what I'm winding up doing is when I'm working with people is continuing to monitor their thyroid and other labs as we're working on them. And they need to usually wind up reducing their dose over time because they're over medicated, right? So the dose they needed when they were 30 pounds heavier is not the same dose they need now. The dose they needed when they had an unhealthy GI tract that didn't absorb things very well is not the dose they need after we've addressed that, right? So they're getting more absorption of their thyroid hormone into the system, which is important. And if we're reducing the cell danger response, they're getting better conversion. We can see that in labs, and you know, it's really good when we can see that in the labs. Give that information to the patient so they can go back to their physician and help work with their endocrinologist or whoever prescribed it to actually start lowering the dose. And you know, to be fair, endocrinologists are kind of cautious as to reduce doses, but I'm starting to see more of them become a little bit more willing to look at somebody and say, oh, okay, yeah, let's reduce it, but let's reduce it slowly, versus, hey, stop doing that dietary thing and eating healthy and living healthy thing and go back to because we're not going to change the dose. That doesn't make a ton of sense to me.
Yeah.
All right, ready? Next one is all right, this one kind of, okay. My doctor, my integrative medicine doctor recommends T3 over T4. We were just talking about this because she said it can't convert to reverse T3 and block the actions of T3. Is that true? So, well, we did a whole podcast on this, right? So you want me to go or you want to go?
No, you can go. It's kind of a loaded question.
Yeah. So this is, I hear this from doctors that are integrative, that the reason they don't like T4 is because T4 therapy T4 medications can convert to reverse T3, and reverse T3 blocks the T3 receptors inside your cells, and that's what's causing your metabolism to slow down. I do not believe that. B, I haven't read literature that justifies that type of commentary. And if your cells are deactivating T4, the same enzyme that deactivates T4 will deactivate T3. I mean, it's the same exact enzyme. So if your doctor thinks that there's no deactivation occurring because they're giving T3 instead of T4, not true. The same enzyme that's being made to deactivate T4, whether T4 is there or not, will deactivate T3. So that part's not necessarily true. The other part that is not really true is that when we're saying that reverse T3 blocks the nuclear receptors and the mitochondrial receptors preventing T3 from binding, that technically doesn't really happen either. Most of the deactivation of thyroid hormone occurs at the cell, on the outside edges of the cell, or outside the cell itself. There is some deactivation of thyroid hormone that can occur at the nucleus. That's been shown as well, but it has not been shown until somebody proves me wrong. I mean, I've read probably over 1,000 papers at this point, and haven't seen any literature or research that shows that reverse T3 binds to the nuclear mitochondrial receptors and blocks it. I've not seen it. I've seen it written in functional medicine stuff, but I haven't seen it in a clinical research paper. So I guess the follow-up question to that would be, then why do sometimes people feel better with T3 than T4? Well, T4 and T3 have to be transported into the cell. It essentially requires more energy to transport T4 into the cell than it is to transport T3. So T3 can get into the cell easier. When T4 is deactivated, it's deactivated to reverse T3. When T3 is deactivated, it's deactivated to one of 4 forms of T2. One of those forms can actually continue to support cell metabolism. So I think that's one of the reasons why they may feel a little bit better because they're getting some T3, which is still doing some of that backup. But the premise that giving T3 therapy instead of T4 therapy is better because it lowers reverse T3, and therefore reverse T3 can't block the actions of T3, that whole part is totally untrue.
Yeah, no, I would agree with that. And that's a common kind of misconception in the functional medicine realm. And I think it was taught many years ago, and I think it's still just being taught without there really being much of a scientific, backup to it.
All right, this is the last one because we're short on time. Okay, you ready?
Yep.
This is the perfect one to end with. How do you fix hypothyroidism? What's your protocol? What supplement? What diet?
Oh, I wish it was that easy, or else everybody would be doing it. We just put out a manual and just send it away. That's the problem, is that there isn't a protocol because every person is different. I think, we've talked about the stressors. It comes down to taking a person and kind of breaking down their puzzle, building their map of what got them there in the first place. And you have to kind of put on your investigative hat. That's why people go, to a functional medicine practitioner to try to investigate that. You can certainly put on your own investigational hat and try to uncover some of these things on your own to work on. We're talking about those stressors. You can start lifting those stressors up and see if you get any sort of symptomatic relief. There's big things that obviously we start with. I mean, those are important things. There's big ones that we say, hey, these are the big things that you have control over. Let's work on. Some of those things may be on emotional stress. Let's manage emotional stress. Let's eat a healthy, nutrient dense, whole food, real food diet, whether that's, it can be many different diets. Again, that's customized for each person. There's not one diet that you can have. And as far as supplements, I'm not a big proponent on pushing tons and tons of supplements. Are they needed to help support to get you to a place? Yes, but there's not one that this person may need digestive enzymes. This person may need a different thing. So there's, again, it comes down to that investigational thing and building the map. And I know that's not what that person wanted to hear, but that's the truth.
Yeah. I mean, it's kind of like if you had, if you had a garage, right? And 10 people brought in their 10 different styles and types of vehicles, and they all weren't working, like me saying, well, how do you fix the car? Well, I don't know. I don't know what's wrong with car A. I don't know what's wrong with car B, C, D, or E. Well, they all don't start. Right. Well, so you have 10 people that show up that say, hey, we're all hypothyroid. How do you fix me? Well, I don't know. It's just like the 10 cars. I don't know what's wrong with each individual car. Well, it doesn't run. Right. That's the name we'd say. It's a non-working vehicle. It's hypothyroidism. But the issue is, why is somebody hypothyroidism? Why is the car not running well? We have to look under the hood and really do our work and investigate. And I would say for the person who asked that question, you and I both know what they want. They want, give me the clear, concise answer, because if you're helping people, then you should have a formula. My medical doctor has a formula. You're hypothyroid, you get a medication, you're done. You have reflux, you get a medication, done. You have constipation, you get a drug, you're done, right? You have high blood pressure, you get a medication, it's done. That is not fixing those people. That is managing their signs and symptoms. That's not what we do in functional medicine. That's not what we should be doing. Mm-hmm. So anybody who tells you they have the thyroid specific diet, that's nonsense. There isn't a thyroid specific diet. If somebody says that, and I just saw this on a post the other day, that they have a thyroid specific supplement that's better than all the other thyroid specific supplements. There is no thyroid specific supplement that's going to fix everybody's thyroid physiology, because the thyroid gland isn't always the problem. It's not a selenium deficiency. What's going on is an adaptive change to excessive cell stress. So I would say, for Erica, for me, our protocol, if you really want to know what the protocol is, Erica was laying it out. Identify what the stressors are that created the problem to begin with. They may be fairly new. They may be decades old. Reduce the load, the stress load, to a point where the danger response goes away. Then you evaluate what systems have become dysfunctional during the time frame. And then you nurture the healing of those dysfunctional systems so that they come back to normal physiology. And then you support health versus managing disease. Now, what does that mean for you, the individual? We don't know, because we don't know what your contributors are. We don't know how long this process has been going on. Is it a decade old? Is it 5 years old? Is it a year old? We don't know. You probably don't know, because what you might think that your hypothyroidism started when you got diagnosed. That's not when the hypothyroid state started. The hypothyroid impact, or the change in physiology, probably started decades before. And unless somebody looked at your abnormal cycles as a 16-year-old and said, maybe that was related, there was problems back then, they would say, no, that your hormone problems have nothing to do with your thyroid problem that you have now. We might argue totally differently, right? Mm-hmm. So the protocol is to look at somebody, their health, their timeline, their signs, their symptoms, a good comprehensive blood chemistry that includes a comprehensive thyroid panel. And then you can come up with a strategy of what's a good dietary place to start, what areas of their life and their habits and behaviors do we have to modify, where do we see dysfunction in the system that we have to help nurture back to normal health, and what other things may be contributing that we have to address. That's the protocol. That's how you fix somebody. But there's no set supplement, there's no set diet, and all of that stuff is just good marketing and sales blogs, I guess. All right?
Yes, absolutely.
All right, so we're done. It was great talking to you again today. Yeah. For those who listen to the podcast regularly, we thank you so much. We continue to have more downloads each month. We're doing our best to get at least 2 of these episodes out a month. If there's questions, concerns, reach out to Dr. Erica or myself and let us know what your questions are. Go to wherever you download the videos and or watch the podcast or listen to the podcast, and please give us a review. I think the higher the star rating, the better. If you have problems though, or have concerns about what we're doing or saying, reach out to us and let us know. Okay. Yeah. Erica, you have a fantastic day. And to the listeners, share the podcast and stay tuned for another episode. All right.
Thanks for listening. Bye.